A 38-year-old Caucasian male was referred for the complaint of progressive diminution of vision in his right eye over the past few years. There was no significant ocular, systemic, or family history. On presentation, the uncorrected visual acuity was hand movements in his right eye due to high myopic astigmatism and 20/20 unaided in the fellow eye. Following application of a rigid gas-permeable contact lens, the visual acuity in the right eye improved to 20/40. At the slit lamp, the cornea in the right eye showed significant ectasia with vertical striae in the posterior cornea that disappeared with pressure and a faint apical scar. Extensive iris atrophy with multiple transillumination defects, mostly in the inferior quadrant, was found. The pupil was 3 mm in size, oval, decentered superonasally, and showed a poor reaction to light. The left eye was normal. Intraocular pressure measured by Goldman applanation tonometry on topical therapy with 3 drugs was 26 mm of mercury in the right eye. The left eye with no medications presented a normal IOP of 13. Gonioscopy in the right eye revealed the presence of peripheral anterior synechiae for 360 degrees and fundus showed advanced glaucomatous changes. The left eye was normal. Specular microscopy revealed a severely abnormal endothelium in the right eye with undefined cell morphology. The left eye showed cells with normal morphology in the normal range. So, what are we dealing with here? In this case, the presence of marked corneal ectasia with apical scarring, Vogt striae, and compound myopic astigmatism are diagnostic of keratoconus. The other findings are not typically present in keratoconus. Here we are dealing with correctopia, iris atrophy, glaucoma, and endothelial abnormalities. Since glaucoma is non-specific and endothelial abnormalities have many causes, let's look at those causes that have correctopia along with iris atrophy and stromal defects. Correctopia and iris atrophy in the absence of serious systemic disorders can occur in the following conditions: iridocorneal endothelial syndromes, posterior polymorphous dystrophy, Axenfeld-Reiger syndrome, ectopia lentis et pupillae, ocular trauma, chronic uveitis, iatrogenic iridectomy, iris incarceration after glaucoma surgery, iris involvement during any anterior segment surgery, cosmetic iris implant, and anterior chamber or iris fixated intraocular lens implants. Let's discuss the features of each and see which fits into the diagnosis of our patient. First, ICE syndromes. ICE syndrome should be considered in the differential diagnosis for any young adult presenting with unilateral iris anomalies, glaucoma, and or corneal edema. The ICE syndrome subtypes are Chandler syndrome, essential iris atrophy, and Cogan-Reese syndrome. This slide shows the features that are common to all the ICE syndrome subtypes. They are common in this age group. Our patient is 38, so this fits in. ICE is more common in women. Of course, this doesn't fit in with our patient profile. This fits in. Our patient has no positive family history and the problem is unilateral. There is no corneal edema in our patient. PAS and glaucoma are present. Iris changes are present. Abnormal endothelium is present. So most of the features are present in our patient. Now let's see the differences in the various ICE syndrome subtypes. PAS are common to all three. In Chandler syndrome, early marked corneal edema is a prominent feature, whereas iris changes are a late change and full thickness holes never occur. In essential iris atrophy, progressive iris changes are prominent, as are polychoria and correctopia, whereas corneal edema may or may not be present. In Cogan-Reese, nodules or pigmented lesions are the prominent feature. So our patient seems to have the features of essential iris atrophy. Posterior polymorphous dystrophy is an autosomal dominantly inherited endothelial corneal dystrophy that is similar to eye syndrome on microscopic examination. Patients may have variable amounts of correctopia, corneal edema, iridocorneal adhesions, and can present with both angle closure and open angle glaucoma. However, family history, bilaterality are not characteristic of our patient, and the endothelial changes characteristic of posterior polymorphous dystrophy are not seen in our patients, so we can rule this out. Axenfeld-Reiger syndrome can be autosomal dominant or sporadic. The iris stroma may be grossly abnormal, including generalized atrophy, correctopia, polychoria, ectropia, and uvea glaucoma. These are all common findings. However, it is congenital and bilateral. Posterior embryotoxin is a prominent finding, and there are no endothelial changes in this condition, in addition to the fact that systemic features may be present. So we can rule this out. Ectopia lentis et pupillae is congenital and may have correctopia, iris transillumination defects, and glaucoma. However, there may be a family history. It is bilateral. There is ectopia of the crystalline lens in the direction opposite to that of the pupil, and the lens is often microspherophakic. So we can rule this out. Trauma can give rise to iris atrophy, correctopia, and glaucoma, but in this case there is no history of trauma. There is no history of previous episodes suggestive of ocular inflammation or findings of old uveitis such as keratic precipitates, K. And even though iris atrophy is present, such large iris defects as seen in our patient are not typical of uveitis. For all these conditions, there should be a history of ocular surgery and evidence of the same. So we can rule these conditions out. So finally, after considering the various possibilities, essential iris atrophy fits in. So the findings in this patient are consistent with keratoconus with essential iris atrophy and advanced glaucoma in the right eye and formifrostic keratoconus in the left eye. I'll give you 10 seconds to ponder on what 2 additional investigations are required in this case. Yes, corneal tomography and visual field analysis. Pentagram showed keratoconus in the right eye with the thinnest point measuring 177 microns, and the left eye formifrostic keratoconus with a central pachymetry thickness of 549 microns. The Humphrey field analyzer showed severe tubular constriction in the right eye. Management issues in the right eye of this patient are vision management, keratoconus management, and glaucoma management. For vision management, according to the American Academy of Ophthalmology preferred practice patterns, glasses should be prescribed for vision if correctable by them. If not, contact lenses may be prescribed. Toric soft contact lenses may be more comfortable in the earlier stages of regular astigmatism. However, as irregular astigmatism sets in, rigid gas permeable lenses may be better for clarity. If RGB lenses are not tolerated, then piggyback lenses, hybrid lenses, or scleral lenses may be used. Next, regarding management of the keratoconus in this patient. The interventional options for keratoconus are intrastromal corneal ring segments, corneal cross-linking, lamellar, and penetrating keratoplasty. The indication for intrastromal corneal ring segments in keratoconus is a progressive deterioration in vision which cannot be corrected with contact lenses or glasses. This patient had progressive deterioration in vision. However, a part of it was due to the glaucoma. Moreover, with contact lens, the vision was 20/40 in the presence of advanced glaucomatous disc damage. So this point doesn't really apply. Corneal thickness of greater than or equal to 450 microns at the proposed incision site is required for this procedure. The thickness in our patient is considerably less in the right eye. Clear central corneas are required. Our patient has mild apical scarring, and intrastromal corneal ring segments are not indicated in subclinical disease, so there is no indication in the left eye as well. So overall, there is no indication for this procedure. Corneal cross-linking is indicated to arrest or slow the progression of corneal ectasia in its earlier stages to preserve visual function and the need for corneal transplantation. Our case is neither progressive nor early. Corneal cross-linking is the first line of treatment for mild to moderate corneal ectasia. Again, same, our case is advanced case, not an early case. In the left eye, the keratoconus is mild, but with normal vision, considering his age and no evidence of progression, there is no indication even in the left eye. A minimal stromal thickness of 400 microns after epithelial removal is recommended to avoid ultraviolet light-induced corneal endothelial damage. The very low pachymetry reading in our patient is a contraindication for this procedure. The indications for a lamellar keratoplasty are corneal scarring or hydrops that fails to clear after several months, contact lens intolerance even if vision is good with the contact lens, and or the patient is unable to undergo procedures such as collagen cross-linking, intrastromal corneal rings, or phakic intraocular lenses. Progressive corneal thinning towards the limbus. None of these are applicable in our patient. The indications for a penetrating keratoplasty are the same as that for lamellar keratoplasty, but with an unhealthy endothelium. Our patient does have an unhealthy endothelium, so DALC cannot be done. But with good contact lens vision and good corneal clarity, a penetrating keratoplasty with its attendant complications is not warranted at this stage. In the future, if the patient develops corneal decompensation due to the unhealthy endothelium, either a penetrating keratoplasty may be performed, or because of the advantages of minimally invasive procedures, one may consider a DALC and then consequently a posterior lamellar keratoplasty. Regarding glaucoma management, the intraocular pressure was uncontrolled while the patient was already on a beta blocker or carbonic anhydrase inhibitor and a prostaglandin analog, which equals maximum medical therapy. The only drug left out is an alpha-2 agonist. Brimonidine produces only a 20 to 30% reduction of intraocular pressure. So one would not expect a reduction of more than 5 to 7 millimeters of mercury. And even though that does come to about 20 millimeters of mercury, the target IOP for this severe glaucomatous damage with 360 degree PAS should be at least not more than 10 to 12 millimeters of mercury, which this drug cannot provide. Laser trabeculoplasty is not an option in this patient as the angle is closed. The only option, of course, left is therefore surgery. The choice of surgery is between an MMC augmented trabeculectomy and a glaucoma drainage device. An MMC augmented trabeculectomy is preferred to plain trabeculectomy in this patient as the number of glaucoma medications and duration of topical treatment is high, thus predisposing the patient to the risk of external bleb scarring if MMC is not used. By the way, MMC is more effective than 5-fluorouracil. Indications for glaucoma drainage devices are failed previous glaucoma surgery, neovascular and uveitic glaucomas, in which conditions glaucoma drainage devices may be used as a primary modality because of the high risk of trabeculectomy failure, other secondary glaucomas, congenital and developmental glaucomas. Now, in ICE syndromes, long-term results are better with glaucoma drainage devices. In this case, a glaucoma drainage device is best, also so as not to interfere with contact lens use by a trabeculectomy bleb. So, to summarize, this is a patient with advanced keratoconus and essential iris atrophy with advanced uncontrollable glaucoma in the right eye and formiferous keratoconus with good uncorrected vision in the left eye. The best form of management for this patient would be to let the patient continue wearing contact lenses for vision and to go for a glaucoma drainage device in the right eye. If you like this video and wish to show your appreciation, you can make a small contribution to help support the channel by way of super thanks. If you click the three dots here below the video window, you will see super thanks. Click on it, choose how much you would like to contribute, and then hit buy and send to complete the transaction. Thank you.